I have the pleasure of introducing Jennifer Gerlach today, who will be giving us a talk called Not Crazy, Empowering Young People Seeking Mental Health Recovery. Jennifer is a clinician and individual in mental health recovery herself. She shares a hope-filled and empowering perspective on youth experiencing psychosis. She's also just published a book called The Psychosis and Mental Health Recovery Workbook, which will be released in May of 2023. This is the first workbook for young adults experiencing psychosis. So please join me in welcoming Jennifer to kick us off today.
Welcome. I appreciate it. Oh, can you guys hear me? Okay, cool. Appreciate y'all attending this. Shoot. Sorry. Yep, there we go. So she said, I am a person who age 13, somebody told me that I lived with something called psychosis, and I didn't believe them, but I was very scared and I was in a hospital. And that was the start of a few years of really struggling mental health services. So, kind of a lot of me stopping medication or professionals having different ideas about what I needed than I thought that I needed. And then also a lot of suffering as far as my own symptoms, depressions, and, fears and fears about demons and thinking I was an evil person. But I consider myself today somebody in mental health recovery. It's something I live every day. It's not something that's a one and done kind of deal. And I know everybody has different perspectives on the labels that we use. So I want to be acknowledging of that. That's just a label that I prefer to use, mental health recovery. And so why I care about this is that my experience is not unlike a lot of young adults who have a first episode of psychosis or other mental health condition of meeting professionals who have very different ideas about what they need than what they believe that they need, feeling disempowered and trying to sort of escape the system. And I think that the only reason I was not successful in that is that I was a minor. I was 13, so my parents could keep taking me back until at least I turned 18. So that's why I care about this. Sure. Yeah, it's okay. I think that the PowerPoint has to be, okay. So just a disclaimer, what I'm going to share is based on lived experience, personal observations, a little bit of research. My goal is to give a perspective. My perspective is certainly not the only perspective. I care to learn from each of you as well. And just want to come in with a place of humility. And I'm also coming from an existential framework. Just show of hands, would anyone of you consider yourselves an existential practitioner or familiar with existential type things? Okay. I'm curious, how many of you guys have conversations with clients about things like meaning, connection, quality of life, fears? They're all existential themes. And so I found an existential framework fits very well with the recovery-oriented framework, but it's something that actually can be overarching and applied to a variety of person-centered, recovery-oriented, even behavioral approaches. So that's kind of going to be the overarching framework I'm going to come from, but definitely want to emphasize that this can be mixed into any type of framework. So from an existential framework, we're looking at meaning making, focus on the meaning of suffering, patterns, addressing loneliness. And those are common themes in recovery too, connection, seeing patterns even in what might be dismissed. I think that's especially true in psychosis, where we see things that might clinically be called loose associations, but if you really look at it, there's something meaningful there. Meaningful reintegration, and not just treatment, but actually quality of life sort of things. 1 in 4 people live with a mental health condition. Y'all probably know that. But the thing is that, psychosis has always seemed to be a little bit treated as a little more other than the others. And I don't know if that's fair, because we all have false beliefs. We all have perceptions that can be tricked. And so, there's something to be said for that, and that it's a very human type thing. In existential work, there's this concept of fellow travelers. And I like that, clinicians being fellow human beings, clinicians and clients all going through the same kind of things of wanting connection, making sense of the realities of life, death, freedom of choice. making sense of understanding and suffering and anxiety and depression and all that. And then we have existential anxiety, which would be to a point of doom. Existential depression would be a point of despair. This existential vacuum, which would be sort of anything that we do to numb that all out. You could think about psychosis falling into all those categories at different points, especially, people are using substances or doing other things to just kind of numb it all out and make it go away. I think about mental illness as something beyond our control. And I'm using that word mental illness. I recognize not everyone has that conceptualization of this experience. And so I want to use it very lightly. But, just for a second, if we can just allow that to be in the room, if you think about the DSM mood disorders, you're losing control of your moods. Anxiety disorders, you're losing control of your thoughts and your experience of arousal. Psychosis, it says control and grounding in reality. You can argue what is reality, who gets to say what reality is, I don't know. But maybe loss of your control and whether or not people think that you're part of their, consensus reality. And OCD is control of thoughts and behaviors. And so this is supposed to be your jurisdiction. And that all gets taken away. When I was struggling most, I was afraid. I did not understand, and I did not feel in control. So I'm curious for you guys, how can clinicians empower a young adult who's feeling they're losing control? What do you guys think? Any ideas? Yeah. Yes. Yes. I love that. Yes. Absolutely. Very much in line with the fellow traveler kind of stance.
Before they come to see me, they already have some skill, right?
Yes.
Already some skill. And then, but sometimes when they're so, when symptoms get worse, they kind of forget or overwhelming.
Yeah.
So we first check their baseline. What thing you do before you find it helpful?
Mm-hmm.
Yeah. Do you think you can try it again? Or I work with you, we can do more?
Yeah.
Yeah.
I love those ideas, giving power back. The music of young adulthood is you're trying to figure out your identity. You're trying to secure relationships for the rest of your life. And it's an uncertain time for pretty much all of us. But you throw psychosis into the mix and there could be some spiraling, you might start losing control of things in your life. Although we have laws in this country about like the Fair Housing Act and the like, we all know that people living with mental health conditions are often discriminated against in housing and struggle with that, way overrepresented in the criminal justice system. The relationships take a hit sometimes. Employment can take a hit sometimes. Choices that used to be in your jurisdiction can seem to be pulled out. And that can feel like a lot of loss of control. And schooling's also difficult because, even in our schooling systems, there often is this loss of control. And so there's a study that showed that, 82% of people experiencing a first episode psychosis had some interruption in their studies. And sometimes this is due to symptoms. Sometimes this is voluntary. But unfortunately, many colleges do have policies that are very ableistic and, will have compulsory leave, be very much pushing the student out of the school, especially if self-harm and suicidal ideation are present. So, if you're thinking about you're already losing control of your thoughts, and then society comes in, you're losing control of that puts you in a kind of rough spot. So how do you regain a sense of agency when everything just keeps getting taken away from you? Do you guys have any ideas on that? You think about somebody who might be experiencing psychosis and maybe they've just had to take a mandatory leave from school. They're not happy about it. How do you help that person gain a sense of agency, or how can they gain a sense of agency?
I think it would help for a person to be creative and to make something that has never been put in the world before, and to put it in the world.
Yeah, absolutely. I think that some of the most creative people I've met have been people who've experienced some type of altered reality or altered state. Absolutely. So, think historically, you have people who are struggling with the sense of loss of control. And the system came in and they tried to take control away from them more to get them under control. So it was treated as something to be controlled. You started out with chains, exorcisms, all that stuff. And we upgraded to straitjackets, insulin comas, lobotomies, treating diseases. The patient versus the practitioner, the doctor's kind of like godlike and the patient's not. Getting better meant that the disease would be subdued and often the person would be subdued. And, the goal was to be stable on meds, maybe. And that's not a very high goal, so it makes sense if somebody would be in that area. If you're already struggling with control, you wouldn't want to integrate, you wouldn't want to be a part of that. But the medical model historically, had getting better as being the symptoms going away. But that tends to lead people to want to fight it off or just give up and say, hey, you know what? I'm a patient now. This is my identity now. Just tell me what I need to do because obviously I can't make choices on my own. And that wasn't good for anybody. So how do you guys think psychosis affects the music of youth and young adulthood? And how do you guys think treatment can affect it too? Yeah. 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 Absolutely. Absolutely. How do you guys think treatment can affect the music of growing up? Think about somebody maybe who's had a couple hospitalizations or is struggling to find a medication regime that they feel good about.
I don't know what you're going for, but I think the music, when you say this concept of music and youth and young adulthood, it's supposed to be fun. Mm-hmm. You're supposed to be able to have these experiences and make friends and do all of these things. And if your family or you or whoever is in control is focusing on treatment and what your meds should be, I feel like fun is taken away.
Yeah.
And you're not getting to connect with other people. And
Absolutely.
You're not getting to build social skills and have all of these, normal childhood experiences
Absolutely.
that your peers are having.
Absolutely. Absolutely. Treatment can be very helpful. I don't want to take that away, and I'll talk about that soon. But before we talk about that, I think we have to admit that treatment can also be traumatic. Having your liberties taken away and put in hospital, being buzzed in and out, that's traumatic. Being in a place where either you or your peers could be put in a seclusion room or room stripped of everything, restrained with either mechanical restraints or physical restraints or sedation, that's traumatic. And, a lot of people, have done a lot of work around, reform of laws surrounding restraint. I would say it's still pretty overused. And I don't know if you guys would agree with me on that. But, an analysis of 8 service users, they asked them, hey, what were your experiences with restraint? They all said it was upsetting. Nobody mentioned it being therapeutic. They said often it was miscommunications, and they found it more to be punishing. So, if your experiences with treatment, especially psychosis, say you have your first hospitalization and you see people going through this, you're going through that, it's kind of something you might not want to engage with. In meta-analysis showed that many people who went through treatment, first episode psychosis found it discrediting, that they were treated like they were less capable, dehumanized, or otherwise harmed in the name of treatment. So the first year I was seeing a psychiatrist, I thought every visit I would be going to the hospital. And unfortunately, sometimes he did send me up to the hospital. It was like he was in the hospital. So I'd go to the outpatient clinic, then I'd go to the upstairs, and that wouldn't be very fun. I'd be very sad about that. How do you empower clients in a system that often has coercive means or is built to focus on compliance? What do you guys think? Yeah, go ahead.
Forced hospitalization is against their civil rights, and that they are able to speak up and point out if they have a safety plan, if they have pieces in place that are alternatives to the hospital, so they're informed.
Sure. That's a very rebel answer. I like it. The psychiatrist is recommending hospitalization, or the therapist is saying, hey, you have got rights. Sorry, go ahead.
I think telling people that they can actually learn how to take back their own control.
Yeah.
Just in general of anything. And if that means helping them learn how to navigate through the system so that they can, whatever they want to do, whether it's, getting housing or getting even better therapy, maybe they didn't like what they're getting.
Yeah.
Something to be able to say, look, I don't like this. I want something else.
Yeah. Absolutely.
And this isn't working.
Absolutely.
What can I do for myself?
Absolutely.
And that I don't have to listen to you just because you're part of the system.
Absolutely. I know a big thing in our area right now is psychiatric advance directives. Are you guys familiar with that? Yeah. Yeah. And I think that's wonderful. You know, it gives the person back control of a time when they might not have control or able to speak on their own. You know, I'm going to talk a little bit more and then I'll talk about the positives of treatment. I promise this is not all like treatment sucks and therapy sucks and we're all doomed. Have a good day. But you know, with psychosis, there's also the stigma even before you get the diagnosis. So there was a study of primary care physicians, and they found that overall, primary care physicians have a more negative view toward mental health than physical health. Is this a surprise to anybody? No, yeah, not a surprise to me either. They were also had a more negative view of people with schizophrenia, just the diagnosis of schizophrenia than depression. Research shows that families at times would fear that the label of psychosis or schizophrenia could have a negative impact on their family member. And this can really get in the way of people getting help. It can get in the way of people following through with help. And, you know, we really have to consider that of, you know, stigma is there and it's there even before diagnosis. And sometimes that delays treatment. You know, when I was going through the diagnosis process, I was sent to a neurologist and a psychiatrist, which is lucky. I know a lot of people aren't given that privilege. But I did a lot of physical tests, MRI, EEG, another EEG. And, you know, I remember I kept thinking, hoping that they're going to find something wrong because I didn't want to think that there was something wrong with me. You know, when it turns out that it wasn't that there was something wrong with me, it turned out that, you know, I live with a mental health condition. It's not my fault. It's not my blame. But how do you guys think blame, either of the family or the self, affects the willingness of young adults to accept help if they see, you know, say psychosis as a character flaw, or the family sees it as they did something wrong? How do you think that affects engagement? Yeah.
I'm only giving you the microphone. I know we can all hear each other, but this is for the folks that are in the virtual world.
Just two things come to mind. One would be if it's something wrong with you, then what is there to help?
Okay.
If there's something inherently wrong with you and you're born with it, it's genetic and everything. And then maybe the other direction it goes is trying to avoid that identity. If you seek help, that would mean that you are the person who's wrong and that it's not going to work anyway.
Yeah, absolutely. Absolutely. It's not me, it's them.
There's a weird thing about blame. I think there's this strange idea that if I have control over my state of being, you know, if I have some control over how I'm thinking, feeling, reacting, intending, etc. If I have control over that, that means I'm to blame for it. I think that's one of the reasons why people are attracted to the idea that, well, it's a chemical imbalance. It's just a chemical imbalance, just a brain disorder. It's just genetic. You know, I don't have any blame for it. But to me, I don't see how anybody could have any blame for anything.
Yeah.
We got to take blame out of take blame out of the language. Because if I didn't choose my parents, I didn't choose my early life, and that has a tremendous impact on my behavior, my state of being. How could I be to blame for it?
Sure. Absolutely. Absolutely. It's a human experience.
Right.
Human experience. Was there anything else? Sorry, I may have advanced prematurely. Okay. You know, we do know that early intervention probably does impact outcomes. And this has been shown over and over and over. Meta-analysis of 17 studies showed that, you know, early intervention in psychosis showed, you know, help throughout the dimensions, you know, more likely to be engaged in work, more likely to be engaged in school, a lower symptom severity. Research has shown that a longer duration of untreated psychosis often correlates negatively with functional connectivity in brain regions. Now, what that means exactly, I'm not quite sure. And I know we could all say, well, causation, correlation, you know, do we say that's a disease process? I don't want to get into all that. But, you know, this is research and this is something that was shown. You know, and there's been a lot of research that supported that maybe for the best outcomes, having some kind of intervention, whether it's psychosocial or something in the first 18 months to 2 years, that could be a critical period in getting things going better for the person. Sorry. Whoa. So, you know, when I first was asked what I most wanted to change about my experience, I would say I didn't want to have appointments anymore. And I didn't want to take meds. I didn't want to talk to my therapist. So knowing this, that, you know, early intervention does improve outcomes, potentially. How would you respond to this? Yeah.
I'm coming.
Actually, I was going to respond to the early intervention piece, if it's okay, real quick. It's important to understand, if you look in Finland, when they do open dialogue treatment, the worldwide incidence of what's called schizophrenia is 2%. And in their country, it is 0.02%, I believe.
Oh, great.
Because they get to individuals so quickly that they don't have symptoms for 6 months.
That's awesome.
And if you don't have symptoms for 6 months, you cannot be labeled that.
That's wonderful.
So it's really important to understand these things are not guaranteed. Our country, it's a year and a half before people are seen. So we want to really consider how quickly you get to be treated well and to talk comfortably is a big deal in preventing escalation or continued discomfort.
Absolutely. Absolutely. So kind of go into this, you know, if someone were to say my goal is just to not be in treatment, an adolescent, my goal is to not have appointments anymore and not take meds, how would you respond? Yeah, go ahead.
I'd say, what's the most important part about that? What are the things you'd be able to do more of? Or the things that you, you know, what's the, I would try to understand from their perspective. Does it feel like it's getting in the way of something? Because I think it's about partnership and understanding. And so I think if the person is saying there's something about this that is unappealing, there's something about this that is interfering with a part of me, I want to know what that is.
Yeah.
So because that can be our mission. Our mission is, okay, well, how do we do this together? Yeah.
Sounds very recovery oriented. I like it. So yeah, and exactly kind of going into that, you know, a study of college students living with mental health conditions in their first episode of psychosis, you know, reported multiple microaggressions, but another study of people hospitalized found that they had the same goals as most people have in that time of work, you know, or time of life, you know, going to school, work, housing, love, you know, those kind of things. So I like that recovery oriented approach of saying, well, what would be the best part of that? What do you actually want to focus on? That's wonderful. Yeah, go ahead.
And I really resonated what she said. And also as a clinician, I usually ask her, if you don't want to go to the appointment, if you won't want to go to the medication, how you want your life to be? And then they say something, okay, how I can work with you to make it happen. And is there any supporting factor for you? And is there any barrier? If there's any barrier, maybe I can help you find some resources, and we can partnership. We can make it happen.
Absolutely.
Yeah, so it's more a trip to get there. In at some point, since I think I need to see you more, so I can get that. Well, then okay, what time work for you?
Yeah, I like that. You know, engagement among people living with the first episode of psychosis, probably unsurprisingly, in treatment, it tends to struggle. You know, on average, 30% of people who refer to first episode of psychosis specialty care will disengage before their providers think that they're ready to disengage. But there's certain things that make a difference to that. Biggest one being lack of trust or level of trust. You know, and that might be something more than just doing traditional treatment. That might be something like sharing the bowl of gummy bears, going for a walk. You know, engagement and work at school was also a positive predictor of engagement in services. So kind of like, as you were saying, you know, if your goal is not to be in treatment, which honestly, I don't think any of us should be our goal, because that's a pretty low goal. You know, what do you want to do? You know, if you want to be in work, let's get you back to work. Let's get you back to school if at all possible. And sometimes the system, I feel like, will say, well, wait until the person's ready, wait till they're ready. When is anybody ready? You know, if somebody wants to do it, I say do it, you know, that, you know, and it might even just be an online class. It might be, you know, working on learning a new language or something, you know, if that's meaningful. Lastly, a belief that, you know, these challenges are caused by social stress, correlated positively with engagement. So kind of as we were going to earlier, you know, this belief that it's my fault, that I'm to shame, that tends to lead people to drop out of treatment, understandably, because I don't want to take that on me. I'm not to blame. I don't want to take that blame. That's a lot. But this idea that, hey, it's social stress may positively correlate with engagement. And some of the research, I don't know if you guys are all familiar with the stress diathesis model. As far as, you know, we all have a certain level of stress. You get beyond that level of stress, you start having problems. You know, some of the research suggests that some of these may be partially stress induced. So it's not an incorrect belief in my mind. So I'm curious, how do you guys define empowerment? How would you guys define empowerment? How would you guys? And there's no wrong answers. I'm not gonna be like, that one's wrong. You don't know what empowerment is. Sorry.
Being seen.
Being seen. I like that. How else do you guys define empowerment?
Being able to make your own choices.
Yeah, absolutely. Being seen, making choices.
When I'm in session and clients bring something up, or like a struggle, instead of like just offering like, we can do this and this, I always ask, what do you need from us to best support you?
Yeah, awesome.
Being able to say, I do like this or I don't like this.
Yeah.
And I want this.
Yeah.
I don't want this.
Yeah.
That's very empowering.
Yeah.
Because I think there was a time for me when I couldn't do that. Mm-hmm. And to be able to say that made me feel proud of myself for being able to speak up.
Yeah.
Because speaking up is not something that's easy.
Absolutely.
I think for most people.
Absolutely. And to do it without consequence. You know, if not, okay, well, you don't like the medicine, you're getting a shot of the medicine. Yeah. You know, something very...
It takes guts.
Yeah, absolutely.
Perhaps empowerment can mean choices.
Yes.
And can mean what those choices look like within someone's capacity or their control.
Absolutely. Mm-hmm. Absolutely. I like that. I like that.
I think for me, empowerment means kind of like being recognized, not just for what I want to do, but for who I am and what I want to do. So for me, it's like empowerment for me is not just being recognized. I want to make these mental health choices for myself because I'm a human being, but I want them to recognize that I am making this choice because I am a Black American making this choice. I'm a person with psychosis making this choice.
Yeah.
And just to know like that's still valid to be under that identity and making the choice as well.
Yeah. Making choices related to identity versus just making choices that are the identity that you're being given by that practitioner. I love it. I love it. You know, here are some ways we can empower our clients. So, you know, first, empowerment to your own perceptions and validation. You know, and this can mean like suspending disbelief, which I know is a big word. When you're talking to somebody who the system might say, hey, this is a delusion or an unusual belief, or this is a voice. You know, suspending disbelief, listening to the person, what they have to say. I have a question, actually. How much do you think that clinical terms like delusion or hallucination are actually, just by definition, invalidating? You guys agree? Because
So in a lot of the work we do, we actually, when I do trainings on topics like this, we have a whole slide about language and about this language, and we drop the term. We don't use delusional to label a person or anything like that. We call it's beliefs that other people have a difficult time understanding, or beliefs that are difficult for others to understand, and then experiences that are, you know, unique to the individual, or things that recovery-oriented language usually involves a lot more words sometimes, and that's okay.
Absolutely. Absolutely. Can I put you on a spot for a second?
Yeah, totally.
Were you the person on the video for the recovery-oriented cognitive therapy through the Beck Institute?
Yeah.
Oh my God. I was like, she looks familiar. That's cool. I love that. Yeah. I love that. Because just by definition, you know, delusion is very invalidating. It's like, I don't believe you and you're wrong. And science says you're wrong. And I don't like how that feels. And I don't want my clients to feel that way. Any other thoughts on that? About how clinical terms like delusion and hallucination can be inherently invalidating?
It's like they're saying you're making it up.
Yeah.
It's not real.
Yeah.
It's just it's just all in your head.
Yeah.
And it's not something that's really out there.
Yeah.
And it makes you go, well, wait a minute. What am I doing here?
Yeah.
If I don't see something that's there, then what are you seeing?
Absolutely.
You know, it's sometimes you end up kind of comparing yourself to other people.
Absolutely.
And then it makes, well, wait a minute. What am I, not a less than a person?
Yeah, absolutely.
Or not not really a good person?
Yeah. Are my perceptions invalid?
Perceptions are messed
if
up.
I think, therefore I am, do I not think to you? Yeah, exactly. Exactly. You know, and just because the reality is not shared doesn't mean it's not real to the person. You know, none of us has the right to say what's real and what's not, honestly. Now, clinically, they're you know, but honestly, we don't, you know, so I don't like those terms, delusions, hallucinations. I like beliefs, and I like visions and voices, or whatever words the person uses. Sometimes people will use words like trauma, stress. I like those terms, and a lot of times I'll just use whatever language the person uses. Empowerment to be human. You know, that these are human experiences. Psychosis even is a human experience. You know, access to peer support can be a big part of it. It's getting to talk to somebody maybe who's experienced psychosis themselves, and to say, hey, like, this isn't actually an abnormal experience. This is something a lot of people go through. Research has shown that peer support has a pretty positive impact on social connection, quality of life, and all that stuff. A turning point in my recovery actually was attending a peer-led recovery group. It was a wellness recovery action planning group. I loved it. Why would encounters with other people with lived experiences, do you think, be important to a young adult having mental health challenges? Why would that matter?
I think of the term normalizing, having a sense of universe. You know, we share universal experiences.
Yeah.
I'm not alone.
Yeah.
I'm not isolated.
Yeah.
I'm part of a community.
Yeah. 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 For me, a big part of it was, you know, people actually get through this and you can have a good life, you know, and that dude's not horrible. So, you know, like this doesn't mean that it's all bad. Go ahead.
I think I might be saying the same thing, but also seeing not necessarily a role model, but an example of someone who feels empowered living with whatever.
Yeah.
The condition, whatever.
Absolutely. 100%. So, you know, I think a big part of empowerment is if peer support's available, that it be made accessible. I know for people receiving services through the public mental health system, it's starting to become very much more common. Unfortunately, in private practice or people who have private insurance, a lot of times it's not as easily accessible unless they go to like self-help groups and things like that. But, you know, I'm a big fan of peer support.
There's one more.
Yeah, go ahead.
So I'm actually 17, so I'm kind of like going through this at the moment.
Yeah.
And I mean, I've been searching a lot for people with lived experience because I think it would be nice to just hear people that have been through similar things, and it makes me feel like accepted. Like some people that actually understand and get it like on a deeper level.
Yeah, absolutely. Absolutely.
I think there's also an aspect to mental illness where it might not be accepted by your friends and family or understood. And so having that acceptance from people who do genuinely understand as best as they can can be really, really empowering as well. And having that support where you might not have any outside of that group.
Sure. Absolutely. Absolutely. Lots of support for peer support. I see one hand in the back.
Oh, we do for them. Oh, gotcha. Gotcha. Yeah, I would also just say it's the first place that I felt like I could just like kind of take my face off and be myself. I didn't have to appear as society wanted me to or the hospital wanted me to. You know, I could just kind of be there in my messy state of self, and that felt very validating.
Yeah. Yeah. It's very non-judgmental, you know, talking to peers, you know. At least that was my experience. I'm sure sometimes peers can be judgmental too, but the peers I was around were non-judgmental, so I give them credit for that.
I know a big part for me of finding a peer community of people with psychosis was not feeling that constant pressure to explain what I go through.
Sure.
Like when I was talking to people who didn't have psychosis when I was first getting treatment, it was always, oh, what's that? And I had to go through this whole explanation of what I experience and what I go through.
Yeah.
But when I was talking to people who had psychosis, there never felt like there was that expectation to explain myself.
Sure. Absolutely. Like it's understood. Understood. Yeah.
There's actually a lot of evidence and research that has shown and proven that peer-led groups really are very effective.
Absolutely.
They're very empowering.
Absolutely.
They actually make people feel like they're part of a really better group of people, not like a defective group.
Absolutely.
But that actually we're part of a community that really help each other.
Absolutely.
And we care about each other because we know so much about what they're going through.
Absolutely. You know, I, before my diagnosis as a teenager, you know, you hear like words like crazy, unfortunately used. And I had a caricature in my mind of what it meant to have a serious mental illness. And I had a picture in my mind of what that looked like. And that was not what I experienced when I went to peer support groups. And it was also cool because when I would be in the hospital, a lot of people go to the hospital and they're in that very worst, right? And I was at my worst and I saw other people at their worst. But in peer support groups, I met people who were in recovery, who were doing well, you know, and that meant a lot. Empowerment to chosen language. I know we jumped on this a minute ago. Some people don't want to identify as a person with mental health condition. Or, you know, maybe they want to identify as a mental health condition. Some people like the person first in language, like person with X diagnosis. Some people like identity first language of I am a blank, I'm a schizophrenic, I'm a bipolar. It's choice, you know. And while I prefer the person first language, I respect the identity first language. I know that's kind of a newer construct. Some people don't want diagnosis at all. They say my trauma, my stress, my experience. And I like that too. You know, people kept wanting me to accept that I had a psychotic disorder. And the more that they would talk to me about having a psychotic disorder, the more I would get crafty about trying to prove that I didn't. And, you know, and then I was told I had bipolar, and then depression, and then OCD, and ODD, like the oppositionally defiant disorder. And I think partially that was just because people were arguing with me and I wanted to argue back with them. I'm not a very oppositional or defiant person, except when people are trying to convince me I have disorders I don't think I had. And these words didn't help me. You know, some of the most harmful things that treatment providers did for me was make comments like, you need to know that you're going to have to know when you have to go to the hospital for the rest of your life. You know, encouraging me to apply for disability, letting me know I would just deal with terrible side effects, painting this picture. So, you know, when it comes to language, you know, empowerment to chosen language, you know, empowerment to even know that we can't tell the future as practitioners. That's very meaningful. You know, empowerment to right and accommodations need to thrive. I know that advocacy was mentioned before. Clinical advocacy and systems is often very necessary and important work. You know, I think that, you know, community support can be one of the most important positions as far as a treatment team, other than the person actually living with the illness. And, you know, we need help sometimes navigating, you know, getting the accommodations we need in school, or, you know, returning to school if you've been told not to return, or, you know, the medical system with the shared decision making. That means a lot. You know, I remember being in a special school advocating to go back. They're going to put me in a self-contained classroom. And I remember the social worker who stood up for me and said, you know, no, actually, I think Jen would do fine in honors classes. And it didn't get me what I wanted. But the fact that she stood up for me, that built a lot of, like, that built mad, like, therapeutic, whatever you call it, therapeutic alliance between me and her. Because you're like, you're helping me out with my goals now. But it also, to this day, it made me think, you know what? Yeah, somebody thinks I can do this. That meant a lot. Empowerment to treatment choices. I know that there's a number of shared decision-making tools out there for things like medication, different things like that. That's outside my scope of practice, but I think it's cool when somebody can be given a list of the antipsychotics, the side effects, and them and their doctor both get to make that decision and talk about it. You know, research shows shared decision-making in general improves engagement and improves the likeliness that the person's going to stay in treatment. and get the help that they need for young people preventing with a first episode of psychosis. So when I first entered treatment, the focus was on compliance, and I was very non-compliant. So that didn't work out too well. But I have a different psychiatrist today, and I'm very thankful for my psychiatrist today. I really like him a lot, and I like my therapist too. Both of them are wonderful people, but my psychiatrist today focuses on my goals. Every time I talk to him, he asks me about how things are going in my life. You know, he never would tell me, you have to take this medication. It's always a shared decision. And, you know, ironically, I'm a lot more compliant with that. So just a thought. You know, empowerment to health and good information. You know, sometimes there are what I consider paternalistic conversations that go on where, you know, the person's told, maybe quote unquote for their own good, this medicine will help you. Nothing about the side effects, nothing about any of that. But we have that right to that informed consent, just as you do with any other medical decision. To the risks and the benefits, you make your decision. We have the right to access quality health care. Research shows over and over and over that people with mental health conditions get poorer physical health care than people without mental health conditions. There's that stigma. And it's really sad. You know, even read a study about people who were in the initial stages of a stroke. People who had a mental health diagnosis on their chart got treatment slower. And this is like, you know, like within minutes in an emergency room, you know, so I think stigma unfortunately has a big impact on that. You know, we have the, you know, right, and, you know, we can empower people to choose their dreams without the label of grandiosity. We are not the seers of all that will happen. We don't have a crystal ball, you know. Has anybody here either themselves or had a client told that their dreams were grandiose? Has anybody ever had that? Yeah. Do you guys think that in all those situations that was accurate? No. So yeah, what's up? No, it's cool. Good.
I often have the conversation with people about how they can actually be happy, joyful, blissful, ecstatic, and that's still not mania. You know, like there's so many experiences that get labeled instead of just, oh, well, let's just look at what you're going through and how and be excited that might just be a wonderful experience. So I think it's right on par with that.
Absolutely. Absolutely. Empowerment to human emotion without that automatically being assumed to be a symptom.
I know a big thing for me was when I first started getting treatment, my therapist and psychiatrist would always ask me, well, don't you have a goal of wanting to be symptom-free someday? Like I was always getting pushed on this idea of being completely symptom-free. But for me, my psychosis is a part of who I am. And I can't imagine my life without my psychosis.
Sure.
So it was always like feeling like I was getting this symptom-free image pushed on me when that's not really what I wanted.
Yeah, absolutely. You know, the right to our choice of dreams, you know, and I personally believe you can be in recovery and still have what the medical system would call symptoms, and that you can not be in recovery and be close to symptom free, at least according to the medical system, because recovery is more about what you want, your choice of goals, your quality of life, and all that. Interesting research. Does anybody here familiar with ACT, acceptance commitment therapy? Yeah. I'm a fan. But, you know, ACT is really big on values, you know, committed action toward your values. And there was a study that showed that, you know, compared with treatment as usual, people who received ACT within a state hospital, you know, setting, they had higher levels of symptoms, but were less likely to be rehospitalized. You know, they were moving towards their values. So again, like symptom severity and presence does not always correlate with quality of life or recovery. And it's really easy for us to get all wrapped up in, you know, is this what we would call a delusion present or not, or are the voices present or not? We don't actually have to do that to empower people, and it might not even be in their best interest all the time. You know, empowerment to, you know, community support, that's more than just a new word for case management. That being said, case management is extremely important, extraordinarily important, like, you know, finding housing, you know, making sure that the person has all the resources they need. But case managers, I feel like that they do so much more than that, and they connect people with the community, and that's just amazing. And, you know, higher levels of social support in the first episode of psychosis is pretty big, you know, makes a big difference into whether the person goes back to the hospital, makes a big difference to their level of distress. You know, loneliness, not having one close friend or family member is strongly linked to distress, as you can imagine. And that's also linked to suicidal ideation in people with, with schizophrenia and psychosis. Non-traditional social interventions, which could include peer support, dog-assisted recovery programs, supported volunteering, doing activities that are not normally considered, like in the therapy manual, like, maybe playing chess with a client or going for a walk with the client or visiting the comic book store with the client. That can be exceptionally helpful in fighting loneliness, but it's not often offered. So how willing are you guys to be a rebel as far as providing these? And it can all be justified in the notes. Like I promise, it's not fraud. I'm not encouraging any kind of fraud. Empowerment to hope. Self-report of hopelessness was correlated to experience of more psychiatric hospitalization, focus group. And, even people like they said the hope was an important part of recovery. So, some of the most helpful things that treatment providers did for me was helping me apply to college. That was something, that same social worker who argued that I should be put back in mainstream school, she helped me apply for college. That I could have a future like any other kid. And I started painting a life myself, not as a lifelong patient, but as a future therapist, speaker, and writer. I've still been free from being in the hospital for 18 years and counting, and I'm thankful for that. So, yeah. Any questions?
We're not here when I announced Jen, and I just want to put another plug in that Jen published a manual, which will be out in May of 2023, the Psychosis and Mental Health Recovery Workbook. So stay tuned, buy it, multiple copies, disseminate it, let your colleagues know. The title, well, there's cards here too. The Psychosis and Mental Health Recovery Workbook. So the first workbook for young adults experiencing psychosis, May 2023. So I'm inviting, I hope that the virtual people can hear me. You are real people, but you're virtual to us right now. Please feel free to type some questions in the chat and I will read them on your behalf.
I am a parent to a daughter who is at risk for schizophrenia at significantly high rates. And I'm just wondering what advice you might have for a parent to provide the care and support, even if she doesn't end up developing it, but things to consider, I guess, that you maybe wish a parent did or have heard otherwise.
Yeah, definitely would say, validation, having a space where emotions can be openly expressed, expressing positive beliefs about, mental health and positive portrayals of people with mental health conditions, saying, hey, this famous person has this mental health condition, or if you ever know anybody that deals with this, they can have a good life. Kind of encouraging those positive beliefs and just, anything you do for any other child, but with that addition of, maybe a little bit of positivity around mental health. Yeah.
Thank you so much for your talk and your story. Really enjoyed it. And I was going to ask about the family side of things too. We work with families who have loved ones that have experienced psychosis or mental illness. And I guess one thing I wanted to bring up too is that if we talk about psychosis as not sharing reality, and we know it's very painful from the perspective of somebody who's experiencing that and no one can share their reality, but it's also painful from the family perspective that they can't share their reality with someone that's very close to them, a child, a parent. Yeah. In my case, my mom has experienced psychosis. And so one, to recognize that. And I do think that part of the empowerment is helping families both heal their own pain around it and also, teaching them about what they're experiencing too. And I'm curious about your work with families, or, you just answered a question about parents too, but how you kind of think about including them and whether that's part of the message of empowerment for you.
Yeah, absolutely. I think family psychoeducation is huge, both for the well-being of the family and for the well-being of the young adult. You know, I know that it's not uncommon for people to have unusual beliefs about a mother or a father or a sibling of this person's out to get me, this person who I have loved my entire life now hates me and they're trying to kill me, you know, things like that. And that is one of the most painful things I think a parent or a sibling could deal with, because it's not something that's often talked about. I refer often to NAMI for the family to family classes. I think that those are a really big support. Any kind of family level peer support, I think that could be helpful, you know, hearing from other family members who have been there, because when you're talking to other family members, they actually understand what that's like. You know, emphasizing that, yes, you may not be able to understand exactly what your loved one is going through, but you can still show them love. You can still show them, hey, I know I don't understand exactly what you're going through right now, but I care about you. We're going to be here for you. You know, we're going to support you. Also, sometimes keeping in mind that, you know, it's not just hard on the loved one. It is hard on the entire family, probably most hard on the loved one, but it's hard on the entire family. I think that's important to keep in mind. And I've also, you know, brought that up to individuals in family sessions as well. And in my private practice, and before I did private practice for a period, I worked in a first episode psychosis specialty program, and family psychoeducation was a huge part of it, because, you know, family psychoeducation is usually a huge part of, well, family's usually a huge part of recovery too. Yeah.
Just to add to that, because I think one of my experiences with some psychoeducation can be that it's very problem focused or very, you know, about understanding perhaps the biology and among other things too. Yeah. But what I like to, if I may, just some of the things I talk to families about is the balance of how do we widen our scope as well and keep doing the things that we do as a family that makes us a family, so that because I think sometimes the individual can lose a sense of identity, the family can lose a sense of identity, that I was mom and now I'm caregiver, now I'm social worker, now I'm and among other roles. And I also define family like people, whether it's friends, whether it's whatever your group is. But I think if we can also do the things that make us who we are. And so one of the things I usually ask families is, what are you all like at your best, and what do you do together, and how do we do those things and keep that going as you have these other things happening as well. So I think it's a balance between understanding and also doing things that make you who you are as a unit. Yeah, absolutely. And I think it is a common thing for family members to almost get displaced, and, you know, our system not being perfect for, you know, maybe a parent or a sibling to be making a lot of phone calls, kind of becoming the caretaker or the social worker. And whenever possible, if, you know, systems of care could be put in place to take over those roles, I think that's ideal, you know, because you can always get another social worker, can always get another, you know, no offense, like you can, y'all are replaceable, the end. No, you can always get another social worker, but you can't get another mom. You can't get another sister. You know what I mean? Like, those core family relationships are so important, and those can become conflicting roles. And if it's possible to keep it separate, that's ideal. It's not always possible, unfortunately, but I think that's an excellent point.
Hi, so my name is Matt Gallagher. First and foremost, I want to thank you for your presentation. I thought it was really helpful. Obviously, you are an individual with a recovery mindset, and you believe in the recovery model.
Yes.
I can't speak for other states, but here in California, we have seen a shift in the other direction, where there is large, widespread clinical model, and the thought that an individual with psychosis or a severe mental illness could live a self-directed life is not a message that is prominent in the narrative, prominent in the Capitol, which is less than a mile away, and really just not a message that is one that is receptive in the community. Yeah. There is a general understanding that individuals with severe mental health challenges lack insight into the mental illness. Medication is the answer. And this journey of a self-directed life is a fallacy that most people cannot accomplish. And so my question to you is, how do we, one, correct that narrative, and two, encourage more professionals like yourself to believe in the recovery model and allow others to benefit from it?
It's difficult. And, you know, I'm from Illinois, and I'm from a part of Illinois quite close to Missouri. And, you know, I know in Missouri especially, there's a big push for guardianship, conservatorship, you know, things of that nature. Involuntary hospitalizations, very easy to get. And I think a lot of it comes out of fear. You know, some of it, unfortunately, I think is fear of liability on the part of the professional. Some of it's false narratives about, the capabilities of the individuals. I think peer support can do wonders here, meeting individuals working alongside professionals that are in recovery doing well. Another piece could be just sharing recovery model or sharing recovery stories. Anything we can do to help eradicate that fear. But yeah, it's difficult. And it seems like a pendulum, it swings from total self-determination to total paternalism and back and forth. And I wish I had a better answer for you than that. I've been reading all of the emails about the care courts and all that. And, it's struggle because, yes, coercive practices might get somebody into treatment, but are they going to stay in treatment afterward? A. And B, is that really ethical, and is that within their support of their quality of life? So, yeah. Any other questions with that?
So I'm going to ask a question from the chat. Someone's asking, is there a time frame that a person that has struggled with a schizophrenia diagnosis that is too long for a person to recover from schizophrenia using the methods mentioned?
Absolutely not. Nope. Anybody, recovery is open to everybody. Yes.
So we are over time, unfortunately. So I want to thank everyone for their questions. Thanks to Jen. Thank you.